Okay, great. Good afternoon, everybody, and thanks a lot for the invitation to this webinar. It's my real privilege to be able to share some of our results, findings, and thoughts on these topics with you today. It's my understanding overall we have about an hour, so I will try and speak no longer than 35, 40 minutes, and then we might have time for questions and discussions. So these are my conflicts of interest that are not particularly relevant for the present talk. And why do we talk about switching from control to assisted ventilation? Because if we think to the trajectory of a patient who undergoes mechanical ventilation, we normally have let's say, a transition between different phases, right? We might start with a phase of non-invasive mechanical ventilation. Then some patients will fail and undergo a phase of controlled mechanical ventilation. And then a progressive decrease in the support that is provided by the ventilator, leading ultimately, hopefully, to a separation from mechanical ventilation and weaning. Now, if we take a look at the scientific literature, guidelines, evidence, there are three main areas of focus of the research: the phase of non-invasive ventilation, the phase of early controlled ventilation with a lot of research focusing on lung protective ventilation, prone position, rescue treatments, ECMO, whatever. And then a lot of focus is also devoted, and rightly so, to the phase of separation from mechanical ventilation, weaning. If you think about it, not that much attention is paid to the intermediate phase, as if the patients were shifted from acute controlled mechanical ventilation to the moment when they are ready for being separated from mechanical ventilation. And I have found that this area could be particularly interesting, especially in two phases. The very early phase, when we start to wake up our patient, light sedation, stop neuromuscular blocking agents if those were at place, with the early transition phase, and a second phase in which, despite our attempts to decrease the level of support, the patient is not able to tolerate the spontaneous breathing, and we need to increase again the level of support to try again and separate the patient after all. And I think these are phases that are particularly delicate in how we set mechanical ventilation, how we manage hemodynamics, how we manage sedation. And as I said, probably these phases do not receive so much attention as they should. So why do we talk about the transition between control and assisted ventilation as a delicate phase? Because we are all aware of the fact that letting our patients to breathe spontaneously has some advantages. There is definitely a bright side of the moon, okay? We may use less sedation, we may decrease the presence of muscle atrophy, as we will see later on. We might improve hemodynamics and obtain a better VQ match. I would like to share with you over the next slides a few examples on why this could be the case. This is a study we performed in Monza many years ago when we tested the application of two levels of pressure support and their impact on the regional distribution of ventilation. On the left-hand side, a higher level of pressure support ventilation associated with a lower level of P0.1 led to a very inhomogeneous distribution of ventilation, whereas the action of the diaphragm was able to drag more gas, if you want, more air towards the dorsal lung region. So the diaphragm acts specifically to the more dependent lung regions being able to generate a more homogeneous distribution of ventilation. Moreover, we are now aware of the fact that mechanical ventilation might not be injurious only for the diaphragm, but also, not only for the lungs, but also for the diaphragm. This is a seminal paper by the group of Samir Jaber showing that the longer the duration of mechanical ventilation, the higher the injury of diaphragmatic sarcomeres. And we have studied by ultrasound the structure of the diaphragm in the phase of the switch between controlled and assisted ventilation. In this study we performed in Monza some years ago, in which by means of ultrasound, we assessed the thickness of the diaphragm, which is, if you wish, a measure, a proxy of the trophism of the diaphragm, exactly as when you take a leg out of a cast because like a bone was broken, and so you had to put the leg in the cast. At the end of the day, when you remove the cast, this leg will be smaller in size. Similarly, the diaphragm tends to lose its thickness while mechanical ventilation goes on. And we have been able to demonstrate that during the day preceding the switch to assisted ventilation, or if you wish, during the progressive during the progression of controlled ventilation, diaphragm lost its thickness till it would get to a baseline, let's say, value. And then here we set our reference. As you see, the switch to assisted ventilation, pressure support ventilation in this case, led to a relatively fast recovery of the diaphragm back to its baseline value. What else? What other fringe benefits do we have from the use of assisted ventilation? Well, of course, we are able to use less sedation, or if you want, it's also the other way around, that when you use less ventilation, you need to switch to some form of assisted ventilation. But in any case, we have retrospectively looked at the number of patients in my previous institution in Monza being switched from CMV to pressure support ventilation. We were able to halve almost the dose of propofol provided to this patient, reduce the dose of fentanyl, and this translated into a less sedated patient early after the switch to pressure support ventilation. And we also notice an hemodynamic impact. I'm sorry if the table is a little bit busy. There was a slight increase in the heart rate, but there was also a significant increase in the stroke volume, leading to an increase in the cardiac output of the patients, without other changes in the macrohemodynamics of the patient, despite a slightly lower use of inotropic drugs. Now, it's also quite interesting to notice that the mixed venous saturation didn't significantly change. So, in other words, higher cardiac output with the same mixed venous saturation means increased oxygen consumption. And this is understandable given the fact that the patients were less sedated. Now, we also have to take into account the fact that spontaneous breathing carries some drawbacks, some inherent risks, which are related, as I just mentioned, to an increased oxygen consumption, as we see, for example, in this slide. This is the oxygen consumption of patients during a progressive decremental trial of pressure support. As you will notice, I tend to refer very much to pressure support ventilation as a common way to manage the patient in assisted ventilation. But what I say, it's not necessarily specific to pressure support ventilation and might also refer to other forms of assisted ventilation, like pressure assist control or bilevel ventilation, or even to some extent to volume assist control. Anyway, when decreasing the level of support from an optimum level associated with a minimal oxygen consumption down by 4, 8, 12, 16 centimeters of water, you notice that there is a profound increase in the oxygen consumption of the patients. And normally, it is the amount of oxygen used to breathe is described around as 5% of the total oxygen consumption. But in this case, in the patients that we are trying to wean out the ventilation, the oxygen consumption can be 30, 40% of the global oxygen consumption. And you can imagine that this might severely impact the hemodynamics and the oxygenation of these patients. We also pay a price to the freedom that we give to our patient, and this will be this will be the focus of the second part of my talk, with a higher risk, with the risk of high tidal volumes that we do not control and high inspiratory pressures. This leads to what has been described as a vicious circle of early or I shall say even late ARDS in a lung that is injured, and for this reason becomes leaky, and there is a leak, a capillary leak into the alveoli, leading to the interstitium and the alveoli, leading to some form of interstitial or alveolar lung edema. This, on one hand, impairs gas exchange, leading to an increase in respiratory drive, but also there is a direct effect, probably because of mechanoceptors in the lung, like J receptors, from interstitial lung edema, leading to a deranged increase in the patient respiratory drive, with a stronger sense of dyspnea and minute ventilation. And in turn, this is achieved by generating negative esophageal pressure, negative alveolar pressure, and worsening the lung injury. This is the concept well known as PSILI, patient self-inflicted lung injury. And I would say that over the last decade, we have been much more aware of the concept of patient self-inflicted lung injury and much more inclined to recognize it at the bedside. I will give you an example of a patient, 37 years old male, with a graft versus host disease and treated with immunosuppression, that then developed a superinfection by a Pneumocystis jirovecii pneumonia. Now, this patient were intubated, required lung protective ventilation, was prone, and after that, 3 times for 3 cycles. And by the way, I would like to use this this time I have, despite it's not the proper topic of my talk, to strongly advocate in favor of prone position in all patients with moderate severe ARDS. And prone position should always be performed before and probably instead of ECMO. Anyway, these patients received 3 cycles of prone position, and finally he was rather successfully weaned to spontaneous breathing, weaned off the ventilator, and extubated. And this is the chest X-ray after the extubation. It's not a perfect chest X-ray, but I should say it could be much worse than this. And this is the trend of the parameters over the course in the course of the next 3-4 days, in the following 3-4 days. We started off from a PF ratio above 350, a PCO2 35, and respiratory rate normal. PF ratio progressively declined. The patient then was put in a head helmet, and then the PF ratio kept declining. And so, to make a long story short, the patient was reintubated with these, I should say, tragic chest X-ray. What I would like to point out is the fact that along with a drop in the PF ratio, we noticed a drop in the PCO2 to 26 and the pH that was really alkalotic, indicating that the patient was heavily overventilating because of the hypoxemia and the deranged respiratory drive. So I'm sure you all have seen cases on patients undergoing worsening of the respiratory mechanics after switch to assisted ventilation or even after extubation. We used to blame superinfection for these cases, but I think we are learning that this is not necessarily superinfection. It could be a sterile, self-inflicted lung injury. There is also an hemodynamic impact. I alluded to the fact that spontaneous breathing, by decreasing the resistance to the venous return, could improve hemodynamics, but on the other hand, we also should be aware of the fact that an increased effort represents an increased afterload for the left ventricle. We always think to the afterload for the left ventricle in terms of arterial pressure, systolic and diastolic, but we also have to consider that if the left ventricle has to pump blood, let's say generating a pressure of 120 millimeters of mercury into the aorta, and at the same time, it is surrounded by a negative pressure of, let's say, 25 millimeters of mercury because of the action of the patient diaphragm. This leads eventually to an increased afterload for the left ventricle. And so, on one hand, this is also the mechanism of several cases of weaning failure due to cardiac failure. That is a frequent cause of weaning failure. Finally, and I don't have time to dig into details of this aspect, spontaneous breathing, especially when the ventilator is not properly set, may lead to asynchronous and to a derangement in the patient ventilator interaction. For these reasons, what I just told you explains the fact that, as nicely shown in this paper by Yoshida, when the degree of lung injury is mild and we let the animal, in this case, breathe, this leads to an improvement of the lung injury, clearance of alveolar edema and cellular infiltration. But if the lung injury is more severe and we let some uncontrolled spontaneous breathing is a little bit of an oxymoron, but anyway, we don't control the degree of effort from the patient. This could in fact lead to a worsening of the animal's injury. Okay, so to summarize this first part of the talk, I think that the spontaneous breathing, the presence of spontaneous breathing in our patient is always could be considered as having a U-shaped relationship, in that a U-shaped relationship. If the effort is too high, we could encounter some risks of injury, like patient self-inflicted lung injury, like myotrauma, in other words, an injury directly caused on the diaphragm by an excessive work of breathing, and left ventricular failure for the causes that I hope I just explained you. Sorry, I lost my slides here on the other screen. Okay, I'm back. And this is typically what happens when our patient is under assisted, okay? Vice versa, a low level of effort of the patient is also associated with the risk of injury, like diaphragmatic atrophy, to the need for a sedation. And again, this is an egg of a chicken question. Ventilator-induced lung injury due to high tidal volume and the risk of asynchronies. This is in turn associated with over-assistance. So the question is, how do we measure the effort of the patient, and how do we judge if assistance is adequate? In regard to this delicate phase of the, so before moving to these two questions, I would like to emphasize a little bit more why I really think that this phase of transition between controlled and assisted ventilation deserves a great deal of attention, both from researcher perspectives and the clinical perspectives. This is a study we published after the COVID pandemics, in which we looked at those patients that were switched from controlled ventilation again to pressure support, dividing them into success, so patients that were able to remain in assisted ventilation for more than 72 hours, and those patients who failed, in other words, that had to return in controlled mechanical ventilation within 72 hours. Our hypothesis was that during the COVID phase, we switched the patients too early to pressure support under the pressure of ICU beds. And this was one of the reasons of failures. And it turned out that it was not absolutely the case, in that the time, the duration, the prior duration of controlled ventilation was exactly the same for patients who succeeded and patients who failed the switch to controlled mechanical ventilation. However, we also found that the failed switch from control to assisted ventilation was independently associated with a worse outcome. Again, it is possible that, given the fact that there is an observational study, so we corrected by a number, we adjusted by a number of factors: age, pre-existing disease, SAPS score, pH. So we tried to take into account the severity of the disease, and despite this, we found that a failure of the switch was independently associated with a worse clinical outcome. It was quite interesting to notice that more or less in the same period, Dr. Perez and colleagues from Argentina were asking the same question. They had a little bit smaller cohort of patients, but with a great advantage of having also non-COVID patients. And as you can see, they also described that a failed switch to assisted ventilation was independently associated with a worse clinical outcome, both in COVID and non-COVID cohorts. This is the Kaplan-Meier for non-COVID ARDS patients. So if it's not the timing that matters in terms of switching from controlled to assisted ventilation, probably what matters is more the physiological condition of the lung and the respiratory system in general. We have looked at the factors that would predict the failure and found that a worse PF ratio, maybe you'll think this is, it's not rocket science, and I agree with you, this is in a way a little bit unexpected finding, but still, even in patients who failed the switch, the PF ratio was not that bad, was way above 150 millimeters of mercury average. Still, it was the strongest predictor of a failure, and the very same was found by Perez and co-workers. So I'm not saying we cannot attempt to switch the patients who have a PF ratio, let's say, below 180, but on this patient, we should keep a special eye. And the other major factors that predicted the failure of the switch to assisted ventilation was driving pressure. Not so much compliance of the respiratory system, rather driving pressure in itself. Again, despite the fact that on average, these values were quite innocent and that we would consider protective. Quite interestingly, some years ago, in this study performed in Monza, they were asking more or less the same question about the switch between, at that time, the term CPPV was very in use. Was very in use. They also found that the difference in driving pressure between patients who failed or succeed was remarkable. These values are not protective, but at that age, the lung protective ventilation was at its dawns, and so we cannot blame the investigators for these findings, but the signal was there, and it's still there already now. So going back to our U-shaped relationship and trying to answer these two important questions: how to measure the effort of the patient, how to measure the global pressure that the respiratory system has to carry, and how to judge if the assistance that we are delivering to the patient is adequate. I always start from the iceberg metaphor, and I'm sorry if you have seen this slide already. I decided that as of 2026, I will not be showing any more icebergs in my presentations because everything needs to change. So this is the last iceberg presentation. Anyway, the concept is that the pressure that the respiratory system has to carry is like an iceberg, okay? You have a part of the pressure that you see on the ventilator screen, which is the airway pressure, and you have a hidden part of the iceberg that you don't see, that is hidden in the patient respiratory system. And exactly as with real iceberg, this part is very dangerous because you do not see it first, and second, because you do not, it can be much larger than the part that you see out of the water. In real iceberg, the ratio is constant. In our patients, it's not. But we will see how to understand what is the total size of the iceberg. So keep in mind the total size of the iceberg represents the total amount of pressure that the respiratory system has to carry. The visible part is the airway pressure. The hidden part is the pressure generated by patients' respiratory muscles. How do we measure the hidden part of the iceberg? Of course, by esophageal pressure. It's a very nice technique in Trento. I am very pleased with the fact that the doctors in the ICU use it at times, but it's not the only tool we have. It's a nice to have tool, but we have several other options to measure the effort that the patient generates and to understand whether the support we are providing is adequate or not. The first workaround is the use of PO.1. PO.1 is a very simple technique. You just have to push a button on your ventilator. All ventilators are providing you with a PO.1. It's a useful indicator of the inspiratory effort, and the ventilator measures the drop in the airway pressure in the first 100 milliseconds against the occluded valve. It's easy to measure it. It's rather easy to interpret it. A PO.1 below 2 it represents a scarce effort. A PO.1 above 4 represents an intense effort. We just had a patient who worked on PO.1 around 10 centimeters of water, no matter what was done. It's quite interesting not only to take a snapshot, to take a picture at the PO.1 of the patient in one condition, but also to evaluate the reaction of the patient to a change in the level of assistance. In this paper, we were able to show that the decrease in the pressure support value immediately generate a steep increase in the PO.1 in those patients who would fail the trial. We highlighted the fact that they were unable to cope with the decrease in the level of assistance that we were providing, whereas patients with a winning success had a lower increase in the PO.1 because, of course, we decrease the level of assistance, patients have to generate more effort, PO.1 raises, but raises more slowly. Another way to assess, so this is a kind of a small glimpse at the size of the iceberg, right? You get nearby to the iceberg and try to guess how big is the size of the entire iceberg by looking at the first part. This is the idea of the PO.1. The other way we can approach the problem is to make the iceberg get out of the water. And how do we do this? We push the inspiratory hold button, okay? The concept is this one. You have two patients here. Actually, it's a very same patient measured 2 minutes apart, okay? So in the left-hand side, you have a pressure support of 15, a peak pressure, let's go back one here, yeah. Peak pressure 20, pressure support 15. So you see a big iceberg out of the water. Here, you dropped the pressure support. So now the floating part of your iceberg has become much, much smaller. Then you push inspiratory hold. And what happens? That the patient relaxes the muscles and you see the global pressure coming back into the system. So on the left-hand side, the driving pressure for a tidal volume of 364 was 14, and on the right-hand side, the driving pressure is exactly the same for more or less the same tidal volume, except that now on the right-hand side, you see the actual global pressure when the patient relaxes the muscles and the global pressure comes back into the system. Okay? So keep in mind, when your patient is spontaneously breathing, plateau pressure may and often will be higher than peak, because plateau pressure in a relaxed condition includes also the pressure that the patient had generated with her or his muscles. What time is it now? Oh, I need to hurry up a little bit. Okay. Not always the patient relaxes the muscles, because sometimes the patient really wants to exhale or really wants to take a new breath. And so the patient will fight against the ventilator. The good news is that this happens rather seldom, only 10-20% of the cases. Second good news is oftentimes is that you can well recognize a nice and flat plateau pressure on the ventilator screen, and this indicates a patient that relaxed the muscles. If the patient is fighting against the ventilator, you will see that the plateau pressure is not there, and the pressure keeps rising up above the after the occlusion. Another benefit of performing an inspiratory hold is to get a value of PMI. The PMI is the difference between the plateau pressure after the occlusion. Okay, here the occlusion starts as the flow goes to zero, and here you have the plateau. And so plateau minus peak is PMI, is the pressure that comes back into the system because the patient relaxes the muscle. It's the muscular pressure that the patient was generating. If you try now to take a deep breath in and let go, the air comes out. If you take a deep breath in and close your mouth, you feel a pressure, okay? Why is there a pressure? Because your muscles generated a negative pressure that sucked air in, and now when the muscle relax, this pressure shows up again. The air wants to come out of the respiratory system, and so in other words, it's the positive pressure that you see when the muscle relaxes was the negative pressure that those muscles were generating. And so, to make a long story short, a PMI in this case of 6 indicates a patient that is actively breathing at the end of inspiration. So, going towards the end of my talk, to give you a little bit of a clinical framework into what is into how this can be applied at the bedside. So let's say it's 9 o'clock in the morning and they tell you that a patient is breathing spontaneously. Okay, this is tidal volume 390. Here you have a peak pressure of 13 because the PEEP is 5 and pressure support is 8. Again, I'm talking about pressure support, but it could be pressure assist control, and it's exactly the same. At noontime, you go back to the patient, and nothing changed in the ventilator settings in red, but the tidal volume is 476. Now, if this was controlled ventilation, you would be happy, because for the same peak inspiratory pressure, the same driving pressure, you have greater tidal volume. So this indicates that respiratory mechanics has improved. However, here we have to take into account the patient component, okay? And in order to do this, we were smart enough to perform inspiratory holds. At 9 in the morning, the plateau pressure was 15 centimeters of water, okay, just above the peak. So the driving pressure was 10 and the compliance of the respiratory system was 39. Now at noontime, the driving pressure is much higher, it's 17. So the tidal volume did not increase because the patient has a better respiratory mechanics, but because the patient has a greater effort. And in fact, if we measure the static driving pressure and we calculate the compliance, we see that the compliance of the respiratory system has dropped. Now, this example is a little bit extreme. This is a mechanical simulator, so it's a little bit mechanics, but I really want to emphasize the concept that you have different components. You have three components at play. The pressure generated by the ventilator that you can act upon. The pressure that the patient generates with the respiratory muscles that you can barely act upon, but you can measure, and the compliance of the respiratory system. These three entities taken together generate the driving pressure global for the respiratory system, so the stress for the respiratory system, and the tidal volume. As an additional technique, we have what has been proposed by the Canadians, which is based on the end expiratory occlusion. Okay, so it's the POCC, which basically relies on the idea of making one tidal breath occlusion and measuring the drop in airway pressure. That is under the assumption of the fact that the patient will generate the same effort that was generated in the previous breaths. So for one breath, the patient does not get any flow, any volume, and we use this to measure the actual pressure that the muscle of the patient generate. This has to be converted by a correction factor of 0.75 and gives us the tidal, the average P mass of the patient. And if we sum this to the driving pressure of the iceberg, so again, the flooded and the visible part of the iceberg, we get the total driving pressure applied to the respiratory system of the patient. And long story short, again, this is my final slides. We have evaluated these concepts in a large observational studies where we assessed the relationship of the driving pressure during assisted ventilation. Again, I am a little bit monothematic in using this scheme, control ventilation and then switch to assisted mechanical ventilation, economy of scale of studies. Anyway, we verified the end inspiratory and then expiratory hold to measure the driving pressure. And we found that both techniques provided a value of driving pressure that was associated with patient's outcome. And quite interestingly, not the peak pressure in itself or the pressure generated by the patients were associated with outcome, but the combination of the two as a static driving pressure and dynamic driving pressure. I'll skip this for the sake of time and go to the conclusion to say that monitoring the patient drive or effort is crucial during assisted ventilation, and especially I would say during the switch from controlled to assisted ventilation. Esophageal pressure is the standard, but we have surrogate methods like PO.1, the inspiratory occlusion, which allows a estimation of patient effort, driving pressure, and compliance. And we should not just focus on the single value, or rather we should look at the patient reaction following a change in assistance. And with this picture of our mountains here in Trentino with some snow, it's snowing even now. I thank you very much for your attention, and if you're interested in these and other lectures, maybe you'll find this research at the QR code useful, and thank you very much for our attention. I hope you're still there, and I didn't talk to my laptop in the last 45 minutes.
No, this was a very
Good.
interesting talk, actually.
This is very
Yes.
reassuring.
This was a very interesting talk, actually, and I think there are many comments and very many questions from the audience. But first, I'd like to introduce Dr. Safa, the president of the ISAC Society. She's with us, and she'd like to thank you for your for joining us in this meeting. Dr. Safa, you're here with us.
Yeah, thank you. Good night, everyone. On behalf of the Egyptian Society of Anesthesiology and Acute Care, I expand my greeting and appreciation for this teamwork, this elegant teamwork, and a special thanks to Professor Giacomo Pillani for his very informative lecture. And every minute it was very interesting. We don't lose any moment during the delivery of your lecture, and I invite you to have more and more collaboration in near future. Especially you are, I think you are Italian.
I think
you
so
are
too.
Italian, so you
Yes.
are my neighbor. You are my
Yes.
neighbor. You go to the north, I am in the south.
I'm very north of Italy, but yes.
We should shake hands and be hand in hand, shoulder to shoulder. Thank you. And
Yes.
I'm so honored that the Egyptian Society of Anesthesiology and Acute Care is the only scientific society that interested in expanding scientific webinars, Zoom meeting, and in-person activities in Egypt. And of course, I will invite all the elegant team to join us in April 8 to 11 in Egypt. Thank you for this webinar. Thank you so much. Thank you, Dr. Muhammad Amin, Abdulrahman Fatir, and Professor Giacomo, and all the attendees. Thank you so much.
Thank you, Dr. Safa, for your hosting this event. And I would just like to ask Dr. Pillani just a question about your experience in this transition, about some specific modes in mechanical ventilation. I know it's a little bit easier to understand this transition from ACV to pressure support, but what do you think, or what's your experience in APRV and PAV mode regarding this transition? The APRV mode and the PAV or PPS, proportion assisted ventilation or proportion pressure support.
Yes. So honestly, I'm sorry to disappoint you a little bit, but I have little experience with both. In that APRV is a technique that sometimes we have been trying, more I should say, as a rescue in patients that maybe were not candidates for ECMO. This was in my previous institution. Sometimes we would try APRV. It's not that easy, I should say, to manage. I'm not saying it's not easy. If you're able to do it, probably it's doable. Unfortunately, I am afraid we still lack a little bit of knowledge on APRV. There is not that many published papers, and in fact, I was talking to a colleague, and I believe that it would be very nice to have a little bit more, even observational data published on APRV. For PAV and PPS, my experience is limited. In that, as you are aware of, those ventilator modes are quite heavily dependent on the type of ventilator you have. You have a little bit more experience with NAVA because Actually, I have been using NAVA quite a lot when I was in Monza, and in fact, I believe that proportional modes have a role. They are much less, well, much less. They are less at risk of over and under assistance. So definitely, I think that proportional modes have a role in this switch. As I mentioned, especially because they avoid over and under assistance. Clearly, these are a little bit dependent on the brands of ventilator you have and on the familiarity you have with these modes.
I think we have question from Ariel. I will try to let him to talk. The question is, what would be the difference between the controlled mode and the spontaneous mode when the level of assist is high in pressure support? Let's say the same level of pressure support in both mode.
Let's say, yes. I mean, if you have let me put it this way. For the same level of inspiratory pressure, the difference between a pressure support or pressure assist control, it's almost negligible. The only point is with pressure control, you have a fixed inspiratory time, which you don't have in pressure support. And in fact, I saw just a picture on LinkedIn. I forgot to put it in my slides, but when, due to the fact that in pressure control, you have a fixed inspiratory time. Sometimes you even see the PMI effect on the waveform tracings without having to push the inspiratory hold button. And sometimes you have patients that are on pressure support, but they just trigger the ventilator and then are passively insufflated by the ventilator in itself. So I came to agree that basically for the same level of pressure, it doesn't really matter whether you're on pressure support or on pressure assist control. The difference is rather minimal as far as the patient triggers the ventilator. If the patient is fully passive, then of course in pressure support there will be no breath delivered. The other advantage, if you wish, of pressure support is you don't have a set minimum rate or maximum. I mean, you don't.
There's problem in the voice, Dr. Bilani?
I think we just lost the sound for a moment.
We lost your sound, Dr. Professor Bilani. No voice. No voice from your side. Ariel, you can unmute yourself.
This technical issue from the internet connection.
Yeah.
Ariel, I think you can unmute yourself.
If you want to speak.
Yes, can you hear me?
Yeah. But the
Yes.
Can you hear me now?
Yeah, we can hear you.
Yes.
Okay.
But we lost the last I think 5 minutes of your answer.
The question about yes.
So I'll try to summarize it. The point is, there are some differences between pressure control and pressure support, pressure assist control and pressure support. But long story short, the difference is not huge. I mean, at the end of the day, the global pressure that the respiratory system has to carry is the sum of the pressure delivered by the ventilator and the pressure delivered by the patients. These two pressures add up to generate the global driving pressure for the respiratory system. And the global driving pressure times compliance leads to a given tidal volume. So this is more or less the same whether you're in pressure support or pressure assist control. The patient requires, the only difference, if you wish, is that pressure assist control has a fixed inspiratory time, and so when the flow goes to zero, sometimes you see the actual PMI, the real driving pressure, showing up on the airway pressure tracings without the need to push the inspiratory hold button. I hope you heard me this time.
Yes,
Yes.
I did very well. It's a great answer. My point, what I wanted to remark, is that the patient could be working hard in a CMB mode, let's say control mode, and also could be working less. So in a few words, not because somebody is in a control mode, that means that it's going to be working less. My point is, like, how do you define a control mode in your words?
A control mode is, irrespective of what the ventilator shows on the screen, is a mode in which the patient is not providing a contribution to the generation of tidal volume. So where the patient is fully passive or is just triggering the ventilator. That's a controlled mode, I should say.
Okay.
We have a question from how far PO1 is sensitive to simplify SILI?
Silly.
Okay.
Well, I think it's quite sensitive, and I'm not sure if we can use it to predict PSILI, but we can certainly use it to monitor patients that are at risk of PSILI, okay, and to find a reasonable compromise between those two extremes of over or under assistance. So definitely a patient that has a constantly elevated PO.1 is a patient at risk of PSILI.
Dr. Mohammed, do you have any questions?
The measure PO.1 is very simple. I saw a question passing by. It's very simple. It depends from the brand of ventilator you have, but they all have this function. Even the lousiest ones, they all have this function. So you just have to find it in the user manual of your ventilator, or look for it in the menus, and you will find it.
Most of the new ventilators does, I think, but in the past it was only Draeger. It's not an advertisement or something, but I think it was initially in the Draeger ventilator in the past. But currently, most of the new ventilators have the pressure occlusion at 100 milliseconds, I think, in its.
Yes, but I think I have to say we have still a few Puritan Bennett's 860 here in Trento that are more than 20 years old, and they measured PO.1 very well. So.
Yes. So I'd like to thank you again for this elegant presentation. It was very useful actually for us. I hope we have many other presentations in the future. Thank you, Dr. Bilani, and thank you, Dr. Faten, Dr. Abdurrahman. Thank you, Ariel, for your contribution. Maybe next time, 1 or 2 months ago, we will have a promise to have you again, Dr. Bilani, if you have time for us. And thank you very much. Yes, thank you. Actually, I like talking about and listening about ventilation. So I think every one of the attendees was much amused from this and benefited from this presentation. So thank you very much. Thank you again.
You're welcome. Bye.
Thank you. Thanks.
See you next time.
Bye.
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 See you. Thank you.